Hello and welcome, everybody. This is Erin Ackenheil. I own Blackpoint Insurance, and we help Medicare beneficiaries learn about the A, B, C's, and D's of Medicare, and we help agents and brokers nationwide learn to launch, grow, and retain their businesses. Every couple of weeks, we do a training that's designed for agents and brokers to really help establish themselves with their Medicare expertise. And we're in the midst of our Medicare Basics series, and today's hot topic is Medicare Part D. The focus of today's training is explaining Part D and educating clients on prospects on how it works, the rules of the road, that type of thing. If you need more information now or after the meeting, you can send me a question or set up a time of appointment to meet with me to figure out how to integrate different solutions into your portfolio. For now, let's go ahead and get started. Today's agenda, Part D, what is it? Prescription drug coverage, how does it work? We'll talk about Part D standard design. So believe it or not, Medicare establishes all the standard design rules for Part D each year. And of course, they change it up on us. So I'm going to go over the 2022 basic design. And then we're just going to go through some high-level Part D rules of the road, considerations, terms that you really need to understand. And then if there's any follow-up questions, we'll take it from there. But for now, let's go ahead and get started. So Part D, what is it and how does it work? So first of all, a lot of people think like Medicare A and B, original Medicare, you can buy Part D prescription drug benefits directly from the government. And actually, you have to buy it from a private insurance company, and you get it in one of two ways. Either as a Part C Medicare Advantage plan, where Part D is included under one umbrella, or as a standalone drug plan that you would pair with a Medicare supplement. A Part C Medicare Advantage plan is when you're on a plan where you're assigning Medicare benefits over to a particular private insurance company, and then they're including Part D prescription drug coverage all under one umbrella. These plans typically have a network. If there's an HMO, a person would choose a primary care doctor and get referrals to specialists within a specific network, and they would have copays. But one of the bonus features would be the embedded prescription drug coverage, along with vision and hearing and dental and other bonus features that are part of these all-in-one programs. Or if a person chooses to go down a Medigap path, something like a Plan G for great or Plan F for fantastic, where they're doing flexible Medicare primary insurance called Medigap, then they would pair it with a standalone drug plan called Part D. The essential overall design is the same. The fact that they're offered through private insurance companies that are the same, but a Part D standalone plan is what you would pair with the Medigap, whereas when you're on an Advantage plan, you're getting everything all under one umbrella. They're always offered by private insurance companies, and they're always following at least Medicare's standard design. Now, when you open the booklet for a Part D prescription drug benefit, regardless of how you're positioning it to your client, the rules are going to look the same because they're all taking Medicare standard design and then making improvements to try to make their plan a little bit more competitive than the next company so that the beneficiary will choose that option. So what you're looking at here is the Part D standard design for 2022. Medicare does change it up a little bit each year, but it's very helpful for you to understand the standard design. And as far as I'm concerned, part of your commitment as an agent is making sure that each Medicare beneficiary understands this and not just the particular copays for the medications they're taking. So understanding this design and how it works is a big part of your job as an agent in helping people along this process. So when you look at phase one, that's what Medicare calls the deductible phase. So the standard design deductible for this year for 2022 is $480. What a deductible means is when your beneficiary is at the drugstore, like CVS or Walgreens or whatever, that first $480 towards their prescriptions is out of their pocket before their plan coverage would kick in for the full calendar year. Now, remember, the private insurance companies can enhance the deductible phase. Often the Part C Medicare Advantage plan, the products that embed all the coverage under one umbrella, often they waive this deductible altogether. So often you'll see your Medicare beneficiaries going in with no deductible. It's not always waived, so you want to be careful to check the summary of benefits to make sure, but commonly it is waived on the Advantage plans or Part C programs. On the standalone drug plans, typically here, you're going to see that there will be a deductible in some form or another. Many of the low-cost Part D prescription drug plans, and by low cost, I mean programs that are under $30, typically they're going to waive that deductible on tiers 1 and tier 2, which are considered generic medications, but on tiers 3, 4, and 5, you'll see that they will have that deductible. There are a couple low-cost plans that don't waive the deductible at all, so you need to check, but typically you'll see that on the lower cost plan. To get a prescription drug plan that waives that deductible fully, usually beneficiaries are paying upwards of $60 or $70 per month to get a plan that eliminates the deductible altogether on a standalone drug plan. Remember, standalone Part D plans are typically paired with freedom of choice Medicare supplement plans like a Plan F or a Plan G. So essentially, when you're evaluating the names, dosage, and quantities of prescriptions that your beneficiary takes, you're going to want to compare this against all the available options to see what produces the lowest overall out-of-pocket cost for deductible. Phase 2 of Medicare standard design is what's called the initial coverage limit, or the ICL. For this year, the ICL is $4,430. I like to describe this as a bank account for medications. So remember, when you're working with Medicare beneficiaries, they may have been on commercial group insurance. They're not used to initial coverage limit and gap coverage. So this is something you're going to want to thoroughly explain. Now, $4,430 is for the negotiated rate of the total cost of the prescription, not what the beneficiary pays, not what the plan pays, but the combination of those, the total. So if the Medicare beneficiary is taking an inexpensive drug for cholesterol, maybe it's a atorvastatin, very commonly taken, the retail negotiated rate on a prescription for 90 days or something like that might be about $30, very reasonable. Frequently, on Advantage plans and many standalone drug plans, beneficiaries would be paying a zero copay for a prescription like that, often seeing the deductible waived for a tier 1 medication. If that's the case, they pay zero and the plan pays $30, they're still getting $30 deducted from their bank account. So that $4,430 goes down to $4,400 until they get the next prescription. Now, it's easy for them to keep track of that because all of the Part D carriers, all the private insurance companies, whether it's a standalone drug plan or a Medicare Advantage Part C plan where the prescription drug coverage is embedded, they're required to send the Medicare beneficiary a notice each month, letting them know how far along they are towards their initial coverage limit. So they're not going to be surprised of how much they've used at the end of the plan year. You can see this when you run the comparisons for them on a pre-enrollment basis to see exactly how much of the ICL they'll use in a given year. If your client is taking medications like atorvastatin and low-cost generics, they're probably not going to use up their bank account in a given year. But if they're taking something expensive, like a brand name medication, they may use up their initial coverage. A great example of this is a prescription we see commonly advertised on TV. It's called Eliquis. It's a blood thinner and it's expensive. It runs about $500 per month. On a lot of the Part D standalone drug plans, your beneficiary is going to be paying the $480 deductible. On most of the Advantage plans, the $480 would be waived. That's an incentive for being on a Part C plan that embeds the prescription drug coverage. Even once that deductible is met, typically there's going to be a higher copay for a prescription like Eliquis. It's frequently covered as tier 3 preferred brand name on many of the plans. A prescription like that could have a copay ranging from $40 to $50 for a 1-month supply. So imagine a 1-month supply of a prescription like Eliquis retails for about $500 per month, and your beneficiary is paying a $50 copay for a total of $500. So $450 by the plan and $50 by your beneficiary equals $500. That full $500 is going towards the initial coverage limit, the ICL of $4,430. And so as a result, you can see by around the 9th month of the year, your beneficiary has used $4,500 worth of prescriptions. Your client is going to go into the gap. So you want to be able to educate your clients that this could happen. If your client goes into the coverage gap, typically the cost of their prescriptions is going to go up. In most cases, that's a 25% coinsurance. The majority of plans aren't going to pay for brand name medications in the gap. So instead of paying a $40 or $50 copay for that Eliquis example, now the price tag's gone up to 25% or $125. So you can see it can jump up and out-of-pocket costs can go up. When you're comparing against what might have been employer group coverage where there was no gap and they were simply paying a copay, you want to make sure you're educating your clients that this could happen and educating them that if they can be on low-cost generics, they may want to talk with their doctor about that because it can save them quite a bit in the long run. But often these are the only examples, the only thing they can take is a brand name. They're looking at this potential gap coverage. Now, the question your clients is always going to have is there a way out of the gap? Is there a way that I can be spending less again on my prescriptions? The only way out of the gap is if their TROOP or their true out-of-pocket spending reaches $7,050 for the calendar year. If that happens, they move on to the catastrophic level of Part D, and typically they're paying 5% of the cost of the prescriptions for the rest of the calendar year. Then come January, it starts all over again with the new basic design for the year. Now, one thing that helps with the true out-of-pocket cost is the drug manufacturers do give the government discounts in the gap. It can be anywhere from 10 to 90% off of the retail price of these brand name prescriptions. That discounted rate, and you can figure out what that is by running your client's medications on Medicare.gov, that negotiated discounted rate actually applies towards the true out-of-pocket spending. So that accelerates how quickly your client is going to get to the $7,050 catastrophic level. So you can be a real educator in explaining this basic design. No company out there can do worse than Medicare's basic design. They can improve upon it, and they typically do, trying to make their plan design a little bit more competitive. There's no replacement when helping your clients with Part D prescription drug coverage with getting the detailed information on what they take. The names, the dosage, the quantity, their preferred drugstore. All of these are factors in help evaluating which plan will work best for their needs. Now, there's a few Part D rules, terms, and considerations I want you to think about. So this is your top 9 checklist that you want to become familiar with. If you're finding you're needing help and getting more information on how these things work, you can always contact me. But there's a few things that I think you're going to want to know about. Your quick checklist. What are the election periods associated with Part D prescription drug coverage? The first election period I wanted to review with you is AEP, the annual election period. This happens every single year. It runs October 15th through December 7th, and changes made to prescription drug coverage during this time take effect January 1st of the following year. So beneficiaries can make changes to their drug coverage, no health questions asked, between October 15th and December 7th. The plans announce their benefits and premiums usually in September of each year. As an agent, you're going to know about that, but you can't release that information to your clients or prospects until October 1st. Between October 1st and October 14th, you can educate and evaluate different plan options for the next year. And then beginning October 15th, you can actually take applications for changes effective January 1st. So this is an important opportunity to evaluate drug coverage for existing clients and to help new potential clients make plan changes for the next calendar year. AEP, very important. IEP stands for the initial election period. This is the initial time when your Medicare beneficiary is, or your client is signing up for A, B, or both. They have the opportunity during their IEP, a 7-month window that surrounds their 65th birthday, 3 months before their birthday month, and 3 months after, to make a decision about Part D. We run into clients at Blackpoint all the time that have missed their initial election period and face a late enrollment penalty later on. Be sure that you become familiar with the rules and get your client enrolled in Part D prescription drug coverage in time. A lot of times they'll say, hey, I don't take any prescriptions, but if they don't take their drug coverage when they're supposed to, they can face delays and penalties later on. So you really want to make sure you take care of them. And then there's a number of special election periods or SEPs along the way. Often, if you work with late retirees, people who kept working and had creditable coverage through their job and have never taken Part D, or moved to a new service area, or have low income, often there can be special election periods available to them to take their Part D prescription drug coverage. In a later training, we're going to go over all the election periods in detail so you can understand the timing around those and what might be available to your client. Now, the second term I want you to become familiar with is formulary. Formulary is a fancy word for a prescription drug list. Every Part D carrier, whether it's a standalone Part D drug plan or it's a Medicare Advantage Part C, where they're embedding the prescription drug coverage as part of the plan, has a formulary or a drug list. Now, the good thing about Part D plans is they have at least 2 medications available in every therapeutic class. So even if it's a 0 premium Advantage plan or a low-cost Part D prescription drug plan, you're not going to be signing your client up for a program that doesn't cover oral cancer medications or medicine for rheumatoid arthritis. They're going to have something on the list for that, but not necessarily every single brand name. So all things being equal, when you go to enroll your client in the program, you're going to try to find a plan that has their prescriptions on the drug list at the best possible pricing. So formulary is a big deal. Now, let's say, for example, they're on the program and what they need is not available on that preferred drug list. It is possible to get something called prior authorization. That's when what you need or what your client needs and is medically necessary isn't on the covered list, or maybe it requires special authorization to make sure its use is appropriate on the plan. Every company has a prior authorization process that your client can work with, and also the physicians can work with to get medications approved. Sometimes plans are going to have quantity limits associated with the prescriptions. Sometimes we know that up front, that they're only going to be getting a certain number of medication per prescription. So for instance, I recently worked with someone who needed to take a prescription, and it typically comes in a 30 pills for 30-day supply. This client takes 2 per day. That's a quantity limit. In order to get that quantity limit overridden, it's going to require a prior authorization. So it just means a set limit of what a person's able to get at one time of a certain prescription. Those can be set, and you'll see those right on your Medicare evaluation of prescription drug coverage. And it can be set when your clients need new medications along the way. But if it's medically necessary to have something different, prior authorizations are possible. Now, one thing you're going to hear a lot about on these Part D prescription drug plans is tiers and copays. Medicare's basic design allows for a 5-tier program. Tier 1 is what they call preferred generic drugs. Tier 2 is considered not preferred generic drugs. Tier 3, preferred brand names. Tier 4, non-preferred brand names. And Tier 5, injectables. And you'll see this design integrated through all the different plans. Each company has different copays for the different tiers, and it's possible for brand and generic medication to appear on any particular tiering. So it's important that you look up names, dosage, and quantity of prescriptions across all the plans. Just because one company has it at Tier 1, another company could have it at Tier 3. And that's why really looking at this and understanding what the copays are and what will work for your client is very, very important. The other thing that you want to think about is the late enrollment penalty. We talked earlier about that client that says, I'm not taking any medication. I would prefer not to take Part D because I don't want to have the additional expense. If your client doesn't have creditable drug coverage from another source that's considered as good as Medicare's Part D program, and they want to add Part D prescription drug coverage late, they'll have a late enrollment penalty associated with their Part D prescription drug coverage. And they essentially get penalized in 2 ways. So if suddenly they need to take a prescription, they won't be able to add drug coverage immediately. They'll have to wait till the annual election period or AEP. And so that can present a problem if they need a medication right away. And the second thing that can affect them is that for every month they didn't have Part D and they were supposed to, there's going to be a 1% penalty based on the national average premium for Part D. So for instance, if they weren't on Medicare Part D for 5 years or 60 months, that would be a 60% lifetime penalty associated with Part D. Now, it's not 60% of some huge number. It's 60% of the national average premium for the year. So this year it's around $33. So they'd be paying a 60% of $33 for this calendar year. But if next year the national average premium is $40, they'll be paying 60% of $40 for that calendar year. If in 10 years the national average premium is $100, they're going to be paying $60 per month in penalty for that calendar year. So it's a lifetime penalty. It doesn't go away. And that's why usually at least a low-cost prescription drug plan makes sense in most instances to ensure that these penalties aren't a factor later on. Preferred pharmacies, just like the list of medications they take and the dosage and the quantity, a preferred pharmacy means that the carrier that they're going with has preferred pricing at that particular pharmacy or that mail order program. So you don't just want to have them going anywhere to get their prescriptions filled, because potentially that pharmacy could not be contracted at all, or they could be contracted at standard rates, which could mean more out-of-pocket costs for your client. So finding a plan with a preferred pharmacy is usually a good idea. Another term you're going to want to know about is IRMA, or Income-Related Monthly Adjustment Amount. When you work with Medicare clients who have a combined income based on the calendar year of 2020 of $182,000, or a single person that has an income of greater than $91,000, they're assessed IRMA charges, Income-Related Monthly Adjustment Amounts. It relates to Medicare Part B premiums, but it also affects Part D as in drug. So if a person is a high earner, the government is going to assess high earner taxes, and that's going to be additional expense that gets billed directly by Medicare for their Part D plan. It can also go the other direction, where people have low income and low assets. They might be eligible for extra help. It's called LIS, or low income subsidy. And that's a great program. We have links available for you on our website that talk about extra help. And if your client is eligible, not only does it help reduce their copays and eliminate the gap, but it can also reduce or eliminate their premium and give them additional election periods to enroll throughout the year. Now, the last thing that I didn't put on here is star ratings. Star ratings are also very important. The government regulates all these Advantage and Part D programs, and they give them a rating each year based on their quality, how easy people are getting their prescriptions and prior authorizations, the customer satisfaction with the drug list, and a number of other factors. All of these go into the particular star rating of the plan on a scale of 1 to 5. So you really want to look at the star ratings as well to help your client determine the best possible option for their situation. So we've gone over a lot of information in a short period of time. Part D is fairly complicated in terms of the overall coverage. You really want to make sure that you get into the weeds and help your clients really understand how the Part D prescription drug plan works and how it applies to their particular situation. Also, once you've got a client on board, it's really important to check each year to make sure they're still on the right plan to meet their needs for the next calendar year, because the basic design changes, the plans can change, the premiums can change, and your client's need can change. For more detailed information on Part D or anything else Medicare, if you need help, please don't hesitate to contact me. My name is Erin Ackenheil. You can visit our website at blackpointinsurance.com, or give us an email, or call the local office. And I also encourage you to follow me on YouTube. We're always publishing educational content that can help make you better at what you do. And if you'd like to work with us as a partner, we'd be more than glad to have you reach out to us. Have a fantastic day, everybody, and thanks so much for your time. Take care.